government gotcha, which the federal government uses to push out a lot of our HIV related materials. If you ever want to know what the federal government is doing with regard to HIV and AIDS, go to hiv.gov. Have it as a bookmark within your website because it gets updated frequently. So you'll sometimes see videos from me talking about what's happening across the federal government. You'll hear from other government leaders about different programs, grants that are out there, all the rest of it. But hiv.gov also has the National HIV/AIDS Strategy, which includes its new vision, goals, identification of our priority populations, where I'm going to spend the most time talking with you all this morning, as well as indicators of progress so we can hold ourselves as a nation accountable. And this strategy is not just a federal strategy because the federal government can't do this alone. It takes the academic institutions, the faith-based organizations, it takes the private sector all involved in trying to end the HIV epidemic. This is a new vision for the National HIV/AIDS Strategy that is reflective of what we want to see in the United States. It also is reflective of the Biden-Harris administration values. So when we talk about preventing HIV, people knowing their status, high quality care and treatment, lives free from stigma and discrimination, so that folks can achieve their full potential across the well-being and lifespan. And then the vision is inclusive of all people, regardless of age, sex, gender identity, sexual orientation, race, ethnicity, religion, disability, geographic location, or socioeconomic circumstance. So in recrafting this vision, we've really embedded it and infused it with the priorities and the values of the administration. Here are our 4 goals. And again, I think as you look at these goals, you can see where community-based organizations or faith-based organizations, as well as federal, state, and local government, all can play a role in helping us move forward. Businesses as well. So, working with Walgreens, working with CVS to try and achieve some of these goals is an important part of the work that we're also doing on the federal level. We also have been working to make sure that in addition to the goals, the strategies and the objectives are all connected. It's a long document, but again, I encourage you to look at different pieces of it. One of the things that's really important is that there are priority populations in the United States that are impacted by HIV at higher rates than other groups. And so what we did in the strategy is prioritize these based on incidence, diagnosis, and viral suppression. And you will see that one of the groups in here is Black women. And so what this means is that Black women have higher rates of HIV incidence, diagnosis, and also Black women in getting into care and treatment often fall out of care and treatment, stop taking their medications. And there are a lot of reasons for that. And I think you guys are going to explore some of those as part of the retreat and also think about how we do some of this differently. Other things that are in the strategy that I just want to highlight are some of these pieces that we were able to also recognize that we need to focus on in the United States. And one of them is realizing that racism is a serious public health threat. And at the basis, there are some systemic and some structural issues that are related to race that also have led to those higher rates of HIV infection among those priority populations that I pointed out. And so, as I have told folks, sometimes when we, for example, don't figure out how women can take care of their children, they might fall out of care because they're going to take care of the children first. If we don't have economic opportunity for women to have them placed in a job where they can be safe and a job where that does no harm, then they may have to result to things like sex work, which put them at risk for HIV in order just to keep a roof above their head, feed themselves or feed their families. So really and truly sort of providing those opportunities and seeing the intersection between those issues and health is really important. And sometimes we talk about them as the social determinants of health. Very often, it's your zip code that determines your health outcomes more than any place else. Sort of where you live and what that zip code is. And we've seen a lot of this and learned a lot about this, especially during COVID. And I've told people, if you didn't know before, COVID certainly showed you and taught you about how your zip code impacts your health. Dr. Fauci, speaking of COVID, likes to say, we have all the tools necessary to end the HIV epidemic. If you look at the suitcase on the left, hopefully it's your left, the prevention suitcase, these are all the tools that we have to prevent HIV. But like I said, none of those make any difference if somebody doesn't have access to them. If somebody doesn't know that PrEP can be used for Black women and thinks that it's only for gay men because they've seen the commercials on TV. If we don't provide access, and let me talk about STI testing too, because there's a really great researcher at CDC, African-American woman named Dawn, D-A-W-N, who has done some fantastic work with a couple of other researchers about STI testing. And what they showed is that Black women, particularly in the South, who test positive at an STI clinic, go and get treated at an STI clinic, are often not offered an HIV test. And anywhere from 1 to 3 years later, seroconvert and become HIV positive, but we're never offered an STI test, an HIV test, even in an STI setting. So again, that's a great opportunity to not only treat them for that STI, HIV test them, and then get them on PrEP. I'll talk a little bit more about that as well. On the treatment side, treatment is evolving fast. At the conference in Montreal, we heard a lot about injectable treatment. Somebody can come in, get a shot, not have to take a pill for 30, 60 days. We're getting up to 90 days long for the shot. So think about it. Once every 3 months, coming in 4 times a year, getting your shot, and it's a wrap. Don't have to think about taking your medication, all the rest of it, which, can be challenging for a whole lot of different reasons. So we're coming a long way when it comes in terms of treatment and prevention. But with these tools in the toolbox, they mean nothing if we don't have awareness and access and easy ways to get to those tools. And we struggle with that, I think, when it comes to women in a lot of different places across the country, Ohio definitely being one of them. The other thing that we need to think more about is a status neutral approach to HIV prevention and care and treatment services. And I'm going to break this down a little bit for you because it is something that you think, why don't we have this? But it goes back to what I was saying about we've created systems and structures that were really meant to keep people out and not keep people in. This is a very simple concept of there should be no wrong door to an HIV test. So testing, we know, is a powerful tool and can set somebody on a pathway to either getting HIV prevention on the left side of this screen, which includes condoms, syringe services, access to PrEP, harm reduction, ways to stay negative. But it's got to start with a test. So we have to scale up access to testing, whether it be in public health clinics, our CBOs, some of our mobile health units. In the Black church, if the Black church isn't doing anything, they're doing food pantry and they're doing a health and wellness ministry. We need to make sure that there's HIV testing connected to all of that so that individuals have access to a test, know their status, and can either get connected to prevention services on the left, or if they test positive, connect to treatment services on the right side of the screen. Because we also know that somebody who takes their HIV medication consistently and effectively becomes undetectable. They also cannot transmit HIV to their sexual partners. which then means we stop the virus from spreading within our communities. So treatment is a pathway toward prevention. And then we also have these prevention tools. This is why this is so powerful. And we say, yes, we can end the HIV epidemic, but we got to think differently and we've got to structure things differently, because instead of being barriers, we need to make access and awareness as easy as possible. I think this is going to be my last slide, because I do want to have some conversation about this. But I show this slide, and I hope nobody gets nervous about the data, because I'm going to walk you through this. That spotted bar graph is the year 2015, and these are new HIV diagnoses in 2015. The more solid turquoise bar graph is 2019. So we're comparing 2015 to 2019. And on the far left of the slide, we have African-American gay and bisexual men. You can see they have the greatest number of HIV infections. So something is definitely happening and going on with our African-American gay and bisexual men. Not a whole lot of difference between that spotted bar graph and that solid colored one. Let's go over one more. Latino gay and bisexual men. Again, not a whole lot of progress there between 2015 and 2019. When people start talking about, oh, HIV is over, and I haven't heard a whole lot about it. This third group of bars here, white gay and bisexual men, that's where you see the most progress. So don't be fooled when people are saying HIV is over, or I haven't heard a whole lot about it. Now I want you to go to our fourth set of bars, moving left to right, and you see African-American heterosexual women. Only a difference of about 400 individuals. So think about it. We're talking about the United States, Puerto Rico, and Washington, D.C., only 400. It's been the decrease between 2015 to 2019. That's 4 years. That's an average of only 100. So we have to do better here, real fast. The other thing that I'm going to show you is, let's move over one more group of bars here and look at people who inject drugs. With this particular group, we're going the wrong direction. And some of this is due to the opioid epidemic. Some of it is also stimulants, because one of the things I've also got to get my federal colleagues to realize is people who use drugs just don't use one drug. You're going to use whatever is available, and sometimes whatever is cheapest. So it might be alcohol and opioids. It might be opioids and meth. I learned in Los Angeles that some homeless women who use opioids will use opioids during the day and meth to stay awake at night, just for safety reasons and because it's also available. So we have polydrug use, but the way we often think about it in our federal and state programs, we think about it and fund it very categorically in like one drug. So we're going to do this for alcohol. We're going to do this and fund this for marijuana. We're going to do this for opioids. We're going to do this for crystal meth, but you can't mix the two funding streams. So we've got to break that apart and stop that and really think about the realities of what's happening on the ground. And speaking of the realities of what's on the ground, that brings me to our conversation that we were having on the streets of Montreal, which was really about the challenges of reaching and engaging Black women as part of the work. And what I had shared on the streets, I gotta watch how I say that. What I shared on our walk. What I shared on our walk, yes, on our walk rather, is some of the challenges. And hopefully, as you all explore the rest of your day, you can figure out how to address some of these challenges. And I'll sum it up with a story. When I was working for the Office of the Assistant Secretary, we wanted to do a national program for PrEP, HIV prevention medications, focusing and targeting Black women, because many Black women don't know that PrEP is available. They don't think it's for them. they don't know about it, or maybe they've seen the commercial and thought, oh, that's for dudes, that's not for me, but it is. And so we thought, let's do this campaign, and let's do a campaign using real women who are on PrEP. So we went to some PrEP providers across the country and said, hey, we want to, feature some women in a national campaign and get them to do this. So they were like, great, terrific. So we had scheduled the photo shoot, and we were doing some of this during COVID, and we couldn't get anybody. And I was like, but I'm going to PrEP programs, I'm trying to figure this out. And what I later came to know, because some women pulled me aside and they said, Harold, here's what your challenge is. So yes, there are women who are using PrEP, but some of them don't want their business to be out there like that. You're asking them to be the face of a national campaign. They're going to be on billboards and on the side of buses and, on federal websites saying, I'm using PrEP. And when you break that down, especially, we were trying to target it in the South, where the HIV rates are some of the highest. And it was like, you're coming up against culture, gender norms. You are coming up against religiosity. For some women to be able to be on the side of a bus saying, I'm taking PrEP, that means I'm having sex, Harold. I may not want everybody to know that. And it was an aha moment for me and the federal team. But what we struggle with is, how do we break through that? How do we get women to understand both their prevention as well as their treatment options? And so I think some of the work that you all are doing, which is women talking to women, and this being something for you, by you, is what's really important and a way to perhaps break through. So rather than being on the side of a bus, is it smaller community conversations? Is it within some of these groups? Is it sort of the health and wellness ministries and being able to have those sort of small group discussions rather than me putting y'all on a federal website? I use PrEP and I'm healthy. No, Harold, there's a whole lot of other messages that people get and receive from women like that are different from men and very different from gay men. So that's part of the challenge. And that's why I'm so excited about you all having this meeting and really thinking about that. Ohio is one of our EHE states, our Ending the HIV Epidemic Initiative, with funding going into your areas to address HIV. And we have some real challenges. And we also have, you all are not the South, but you all are the Midwest. And I grew up in Chicago, and we call it the Mississippi of the North, because I know I have, my grandmother came up from Laurel, Mississippi. My grandfather came up from Baton Rouge. And for my grandfather, the story's history is at 6'2" and 16 years old, he was a potential target for lynching because he spoke his mind. He didn't do yes, sir, no, sir, especially to 11, 12-year-old white boys. And when he was 16, so his mother said, I'm sending you to Chicago. So I know Midwestern culture is different from Southern culture, but we got some elements going on from sort of our histories that also, some of those elements put us at risk for HIV. Some of those elements put us at the ability to fall out of care. The thing I also tell people is that culture and our relationship with the medical profession also gets in the way, and we need to think about that. It took me a long time as an adult to get the voice of that little Black woman who raised me out of my head, because my doctor used to tell, so my mother, my parents divorced when I was 11. So mom, raising us as a single mom, my relationship with medicine and healthcare was, boy, your mother has a job. If I have to take you to the doctor, you better really be sick. You better not be playing. This better not be an excuse to get out of school. I'm taking off work. And at that point, we were going to get on the bus. We were going to get on 2 buses and go to the doctor from where we lived on the south side. So you better really be sick. So the way that translates as an adult with a good federal job and insurance is I used to wait till I was really sick to go to the doctor. I had to be really sick. Maybe I slept on it wrong. Maybe if I cook up some greens, I'll feel better and eat that, I'll feel better. and my doctor had to tell me, no. He's like, why are you still doing this? You have other choices. You have other options. You need to stop listening to the little Black woman that lives in your head that tells you, wait, you better really be sick in order to go to the doctor. That's not the way this should work. But culturally, that's the way I was raised. And I had to undo some of that in order to have better health outcomes. So that's some of the stuff that's going on that I'm hoping you all can unpack and begin to think about, how do you craft a better health future for women in Ohio?